Good afternoon, ma'am.
Good afternoon. Good afternoon.
Good afternoon, ma'am.
Good afternoon.
Good afternoon.
Good afternoon, ma'am.
Good afternoon, students. Okay, so hello to all of you students. Today we have second lecture. So first of all, I want to ask you, is my presentation visible on the screen?
Yes,
Yes,
ma'am.
Oh, great. Very good. So let's begin. So today our lecture will be divided on two parts as previous time. But the amount of the information which I want to share with you is very big. And you will have to understand a lot of hard things. So, as I said, this lecture will be divided on two parts. First part will be about examination of the patients with cardiovascular system pathology. And second part, I will give you information about examination of the patients with gastrointestinal system disorders. Now, first of all, to begin with cardiovascular system as a first part of our lecture, I want to refresh your knowledge about its anatomy and physiology as it is important for understanding methods of examination. So the heart is located in the chest between the lungs, behind the sternum, and above the diaphragm. It is surrounded by the pericardium. Its size is about that of a fist, and its weight is about 250-300 grams. Its center is located about 1.5 centimeters toward to the sternum from mid-clavicular line. The heart itself is made up of 4 chambers, 2 atriums, 2 ventricles. There are few main blood vessels which connect to different chambers of the heart: the aorta, the pulmonary trunk, the pulmonary veins, inferior and superior vena cava. There are 4 valves. Valves are fibrous flaps of tissue found between the heart chambers and in the blood vessels. They are rather like gates which prevent blood from flowing into the wrong direction. Valves between the atria and ventricles are known as the tricuspid and mitral valves. Valves between the ventricles and the great arteries are known as aortic valve and pulmonary valve. There are 2 main types of cardiovascular circulation: pulmonary or lazy circulation and systemic or greater circulation, and they are responsible for oxygenation and circulation of the blood through the body. Also, we should remember about the arteries of the heart that form the heart circulation, or also called coronary circulation. Is the circulation of blood in the blood vessels that supplies the heart muscle, namely myocardium. Now, please watch a short video about mentioned information. Так, students, I will play it for a few seconds. Please tell me, is it audible or not, okay?
Okay, ma'am.
The normal heart has 2 sides.
Audible, yes?
Yes, ma'am.
Thank you.
And 4 chambers: the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called the ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. The pulmonary artery splits into 2 vessels, each going to the lung. As that red blood cell makes its way through the lung, it returns through the pulmonary veins. That blood is now oxygenated to pick up oxygen, then goes across the mitral valve, which does most of the work in terms of delivery of blood to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
Well, next is cardiac cycle. So it is a period of time that begins with contraction of the atria and ends with ventricular relaxation. So the cardiac cycle proceeds in 3 phases. Atrial systole lasts about 0.1 second. Ventricular systole lasts about 0.3 seconds, and complete diastole lasting about 0.4 seconds. Consequently, together the whole period of cardiac cycle takes 0.8 seconds. Now, let's watch video about mentioned information.
The cardiac cycle are all the events that occur in single heartbeat, and the events that occur in a single heartbeat are the alternating contractions and relaxations of the heart. Contractions of the myocardium is what we call systole, and during systole, the myocardium of the chambers contract, causing the chambers to squeeze blood out. Relaxation of the myocardium is what we call diastole, and during diastole, the myocardium of the chambers relax, allowing the chambers to fill with blood. There are 3 phases of the cardiac cycle. The first phase is called atrial systole. During atrial systole, the atria contract, forcing blood into the ventricles. The second phase of the cardiac cycle is called ventricular systole. And during ventricular systole, the ventricles contract, forcing blood either into the pulmonary trunk or into the aorta. And finally, the last phase of the cardiac cycle is atrial and ventricular diastole. During atrial and ventricular diastole, both chambers, atria and ventricles, relax, allowing blood to passively fill each chamber.
Well, as usual, we begin our examination of the patients from questioning or subjective examination. So if the patient is suffering from the cardiovascular problems, patient may have next specific complaints: pain in the heart region, edema, palpitation, dyspnea, asphyxia, cough, intermissions, and syncope. As a non-specific, we may find fever, sweatiness, weight loss, fatigue, pain in the abdomen and in the joints, headache, dizziness, deranged vision and hearing, voice changes, etc. So, pain in the heart region as a main complaint of the patients with cardiovascular problems. If patient come with pain in the heart region, next characteristics of the pain should be clarified. As always, location, character, type of the pain, frequency, duration, radiation, associated features, provocation, and relieving condition. There are next causes of cardiovascular chest pain. A blockage of coronary arteries can lead to a heart attack, acute coronary syndrome, stable or unstable angina, Prince-Metal's angina, myocardial infarction, aortic stenosis, hypertrophic cardiomyopathy, aortic dissection, pericarditis, cardiac tamponade, arrhythmia, myocarditis, mitral valve prolapse syndrome, and aortic aneurysm. Next is cardiovascular edema. One of the most common cardiac problems associated with edema is congestive heart failure. When the heart weakens and pumps blood less efficiently, fluid can slowly build up, creating leg edema. If fluid builds up quickly, patient can get fluid in the lungs. If the heart failure is on the right side of the heart, edema can develop in the abdomen. If the heart failure progresses, edema increases and transsudate may accumulate in the body's cavities, in the abdominal cavity, so-called ascites, pleural cavity, hydrothorax, and in the pericardium or hydropericardium. General distribution of edema through the entire body is called anasarca. Patients with cardiac pathology quite often complain of edema, but we must not forget that edema can be a typical complaint and for the patient with kidney disease. So we should know how to distinguish them. Cardiac edema has ascending character, starts from the low extremities and spread upward. Renal edema has descending character, starts from the face and spread downward. Cardiac edema arises more prominent in the evening, renal edema more pronounced in the morning. Skin in cardiac edema is cyanotic and cold, and in renal is pallor and warm. Next complaint is palpitation. Is an uncomfortable awareness of the heart rate. Normal palpitations occurs with exercise, emotions, and stress, or after taking substances that increase adrenergic activity or decrease vagal activity. Pathological attack of palpitation arise mainly as a result of organic affection of the myocardium in the coronary heart disease, pneumocarditis, pericarditis, heart valvular disease, cardiac tumor, myocardiopathy, mitral valve prolapse, ventricular preexcitation syndrome. Attack of palpitation with the heart rate over 160 per minute, it is paroxysmal tachycardia. This is a sudden acceleration of the cardiac rate. Attack of paroxysmal tachycardia may last from several seconds to even few days and terminate just as unexpectedly as it begins. Paroxysmal tachycardia arises in the patients with organic affection of the heart, in myocardial infarction, heart valvular diseases, in cardiosclerosis. Next is dyspnea. Is a cardinal symptom of the left heart failure and occurs in many other cardiovascular conditions. It occurs in the patients with left heart failure, with angina equivalent, fluid overload, also anemia and obesity. The New York Heart Association classification provides a simple way of classifying the extent of heart failure. It classifies patients in one of four categories based on their limitations during physical activity. The limitations or symptoms are in regards to normal breathing and varying degrees in dyspnea or angina pain. Next is asphyxia. Asphyxia is an attack of a grave dyspnea that occurs due to acute congestion in the lungs and upset of gas exchange in acute left ventricular failure, and observes in the patients with myocardial infarction, aortic stenosis, and regurgitation, and also in some cases in essential hypertension. Attack of asphyxia, which are known as cardiac asthma, arise suddenly at rest or soon after physical or emotional stress, and usually during night sleep. Next is cough. Cough in patients with cardiovascular disease is due to congestion in the left circulation. Cough, as a rule, at first is dry, arises during exertion, and particularly in the lying posture of the patient. In prolonged congestion, cough is with sputum. Next is hemoptysis, and in cardiac pathology is mostly due to congestion in the left circulation and rupture of fine bronchial vessels during coughing. Next are complex of headache, dizziness, insomnia, deranged vision, and hearing, which arise most common in arterial hypertension, also may be observed in heart valvular disease, aortic stenosis, aortic regurgitation, and of course heart failure. One more complaint is syncope, is sudden loss of consciousness. Cardiac syncope is caused by a sudden drop in cardiac output and recoverable loss of adequate blood supply to the brain, which is called cerebral ischemia, due to an arrhythmia or a mechanical problem. Common causes of cardiac syncope are arrhythmia, bradycardia, especially Sixinus syndrome, complete atrioventricular block, also tachycardia, especially ventricular tachycardia, also ventricular preexcitation syndrome, atrial fibrillation and flutter, structural heart disease, ischemic left ventricular dysfunction, aortic stenosis, mitral valve prolapse, hypertrophic obstructive cardiomyopathy. Finally, intermissions, are also called escaped beats, are due to disorder of the cardiac rhythm. Patient described it as a feeling of disordered activity of the heart, stroke of the heart of various strain, or stoppage of the heart. Intermissions may develop during exertion or at rest. and may intensify in special posture of the patient. Intermissions are clinical signs of atrial fibrillation, extrasystoles, and heart block. As always, after subjective examination, we have to conduct a physical examination. Therefore, our plan of physical examination of patients with cardiovascular system disorder consists of inspection of the heart region, palpation of the heart region, percussion. Here we have determination of absolute and relative cardiac dullness, and auscultation of the heart. So step 1 on the physical examination is inspection of the heart region, and we should evaluate the presence of deformation of the chest in the heart region, such as cardiac humpback or effusive pericarditis. Also, presence of the apex beat, presence of the pathological pulsation in the heart region, and presence of the remoted pathological pulsations. Second step of physical examination is palpation of the heart region, and we should estimate location and properties of the apex beat, determine the cat's paw symptom presence, and palpate if present pulsated liver. So point A in palpation of the heart region is estimation of location and properties of the apex beat. A normal apex beat is found in the fifth intercostal space, 1 or 1.5 centimeters to the sternum from the left midclavicular line. So the displacement of the apex beat usually indicates enlargement of the heart, which is called cardiomegaly. Point B is determination of the cat's paw symptom. Cat's paw symptom is a thrill of the chest wall in the heart region, low vibrating murmur, which resembles purring of the cat. This sign is of a great diagnostic significance. The cat's paw symptom is palpatory equivalent of cardiac murmur in organic heart valvular disease. And point C in palpation of the pulse is palpation of the pulsated liver. True and transmitted pulsations are distinguished. True pulsation is observed in tricuspid regurgitation due to regurgitation of blood from the right ventricle to the right atrium during the systole, overfilling of the vena cava superior, and liver veins. Therefore, liver is enlarged during the diastole, and positive venous pulse is determined. Transmitted pulsation is characterized by movement of the liver in the one direction and is caused by transmission of the heart contractions. Third step of the physical examination is percussion of the heart. So examination plan consists of determination of borders of the relative cardiac dullness, determination of borders of the absolute cardiac dullness, determination of the transfer rate of the heart, borders of the vascular bundle, and finally configuration of the heart. Point A in percussion of the heart is determination of borders of the relative cardiac dullness. It is the projection of its anterior surface on the chest. The relative cardiac dullness corresponds to the true borders of the heart. Relative cardiac dullness borders are displaced because of the heart chamber dilation. Borders of relative cardiac dullness are next. Right in the fourth interspace, 1 centimeter laterally of the right edge of the sternum. Left in the fifth interspace, 1 and 5 centimeter medially of the left midclavicular line. And upper in the third interspace in the left parasternal line. Next is determination of the borders of the absolute cardiac dullness. It is the projection of the anterior surface of the heart, which is not covered by the lungs onto the chest. Absolute cardiac dullness is formed by the right ventricle here. So borders of absolute cardiac dullness are next. Right in along the left edge of the sternum from the 4th to 6th rib. Left in coincidence with the relative cardiac dullness, fifth intercostal space 0.5 centimeters medially of the left border of the relative cardiac dullness, and upper in lower edge of the fourth rib along left parasternal line. Point C in percussion of the heart is determination of the transfer rate of the heart. Transverse rate of the heart is the sum of distance from the right border of the relative cardiac dullness to the anterior median line near 3 to 4 centimeters, and from the left border of the relative cardiac dullness to the median line near 8 to 9 centimeters. The transfer rate is measured by a measuring tape and normally is 11 to 13 centimeters. Enlargement of the cardiac transfer rate is observed in hypertrophy and dilation of the heart chambers. Point D in percussion of the heart is determination of the borders of the vascular bundle. So, the vascular bundle including aorta, vena cava superior, and pulmonary artery is not simple to percuss. The borders of the vascular bundle are determined by light percussion in the second intercostal space from mid-clavicular line to the right and left towards the sternum. The borders of the vascular bundle are normally found along the edge of the sternum. The normal width of the vascular bundle is 4 to 6 centimeters. And point E in percussion of the heart is determination of the configuration of the heart. Configuration of the heart can be determined by percussion in the second, third, fourth intercostal space on the right, and second, third, fourth, fifth intercostal space on the left. For defining of heart configuration, the borders of right and left contours of relative cardiac dullness are additionally defined by percussing in the right third intercostal space and in the left third and fourth intercostal spaces. Having connected all the points corresponding the border of relative cardiac dullness, one can obtain the idea about heart configuration. So, in this slide is an X-ray on which is visible normal configuration of the heart. There are also pathological configurations of the heart: mitral, aortic, trapezoid, and corbovinum, also called bullish heart. Step 4 of the physical examination is auscultation of the heart. So, auscultation of the heart is objective method based on listening a noise within the heart during cardiac cycle. So, heart sounds, normal or pathological, are caused by turbulent blood flow. They include the sound of the closing heart valves. The overall sensitivity of auscultation is high for identification of congenital heart diseases, significant valvular diseases, and persistent cardiac arrhythmias. Sensitivity is lower for primary myocardial or pericardial diseases unless there are obvious associated abnormalities such as a murmur, arrhythmia, or prominent friction rib. So there are 4 main areas of auscultation. Area of the apex beat for auscultating the mitral valve. Lower part of the sternum near its junction with the xiphoid process is the point of auscultation for the tricuspid valve. Valves of the pulmonary tract are best heard at its anatomical projection onto the chest, mainly in the second intercostal space to the left of the sternum. Aortic valves are best heard in the second intercostal space to the right of the sternum, opposite to pulmonary valve, where the aorta is the nearest to the anterior chest wall. Heard sound, which are associated with the contraction of the aortic and mitral valves, or which developing during its affections, can be heard to the left of the sternum at the third or fourth intercostal articulation, the so-called fifth listening post at the Botkin-Erbs point. So auscultation of the heart in such sequence, first is mitral, then aortic, pulmonary, tricuspid, and Botkin arcs, is carried out due to the fact that in such sequence, the frequency of valve damage is reduced. Most often affects the mitral valve, less often tricuspid valve. So, examination plan during auscultation should include evaluation of the following items: heart rhythm, heart rate, heart sounds, presence of the splitting and additional sounds, and presence of the heart murmurs. Heart rhythm in healthy subjects, S1 and S2, S2 and S1 follow one another at regular intervals. The heart activity is said to be rhythmic or regular. When the cardiac activity is arrhythmic, the heart sounds follow it in irregular intervals. Heart rate in normal condition is 60 to 80 beats per minute. Acceleration of the heart rate to more than 90 beats per minute is called tachycardia, and heart rate less than 60 beats per minute is called bradycardia. Next, in examination plan of auscultation is assessment of the heart sounds. Therefore, the work of the heart is accompanied by sound effects, which are perceived by the ear and are conventionally called sounds. Normally, in healthy individuals, two sounds are heard at all points which was mentioned above. First sound, S1, is produced during ventricular systole. That is why it's called systolic sound. Second sound, to S2, occurs at the beginning of diastole. That is why it's called diastolic. First sound is a dull, prolonged flap, marks the onset of the ventricular systole. Second sound, a short, sharp dub, occurs at the beginning of the ventricular diastole. The first sound is caused by closure of the mitral and tricuspid valves, and the two sounds tend to merge as one. When considered separately, the closure of the mitral and tricuspid valve is called M1 and T1 respectively. The second sound, S2, is caused by closure of the aortic and pulmonary valves. They are slightly apart with the aortic component, also called A2, slightly after the pulmonary closure called P2. Now please watch a video about mentioned information.
There are two types of heart valves. One between the atrial ventricles and either the pulmonary trunk and the aorta. Valves closing. We call this stub. We call this stub. So when you're actually hearing due to the
Well, next we will discuss diastolic sounds. So diastolic sounds include the following. Second one, which was mentioned already. Third and fourth heart sound, S2, S3, and S4. Unlike systolic sounds, diastolic sounds are low-pitched, they are softer in intensity, and longer in duration. Except for S2, these sounds are usually abnormal in adults, means S3 and S4. Although an S3 may be physiologic up to age 40 and during pregnancy. So, next characteristic features, or better to say, plan of examination of auscultation include assessment of the heart sound by the following criteria: location, timing, changes in intensity, splitting of heart sounds. So, loudness of the heart sounds depends on the point of auscultation. If the first and fourth listening point, first heart sound S1 is louder than second one. In the second and third listening points, second heart sound is louder than the first. The second sound of the aorta and pulmonary artery is of the same loudness. The timing of the heart sounds can be described as during early, mild, or late systole, or early, mild, or late diastole. Changes of heard sound sonority can be characterized by sound decreasing or weakening, sound increasing or intensification, splitting of sounds, and appearance of additional sound. Point 4 in examination plan during auscultation is presence and characteristics of splitting of the heard sounds and extra heard sounds. It may be revealed in auscultation, which are caused by asynchronous work of right and left chambers of the heart. Splitting is when two short sounds follow one another at a short interval, and therefore they are not perceived as two separate sounds. Extra heard sounds are triple rhythm, gallop rhythm, systolic click, and pericardial knock. In addition to the normal heard sounds, abnormal sounds known as murmurs may be heard. So cardiac murmur may be both endo and exocardiac. Endocardiac are organic, and they may be acquired systolic and diastolic and congenital systolic and diastolic, and functional systolic and diastolic. And diastolic, here we have Flynn, Graham Steele, and Coombs. And finally, exocardiac or extracardiac murmur are pericardial, pleuro-pericardial, and cardiopulmonary. So first was mentioned endocardiac murmurs, and they occur most frequently. These may occur in anatomical changes of the structure of the heart or organic murmurs, or in dysfunction of the intact valves, so-called functional murmurs. Cardiac murmurs may not be audible over all areas of the chest, and it is important to know where it is heard best and where it radiates to. For example, systolic murmur due to mitral valve incompetence is best heard at the heart apex. It can be transmitted to the axillary area or into the second and third interspace to the left of the sternum. Diastolic murmur generated in a narrowed mitral valve is usually heard over a limited area at the heart apex. Systolic murmur due to stenosed aortic orifice is heard in the second interspace to the right of the sternum. As a rule, it is well transmitted by the course of the blood flow onto the carotid arteries. Since this heart defect is characterized by a rough or loud sound, it can be determined in auscultation over the entire heart region and be transmitted to the interscapular space. Diastolic murmur due to aortic valve incompetence is best heard not over the aortic valve, but rather at the Botkin-Erb's point, where it is transmitted by the backflow of blood from the aorta to the left ventricle. Next have to be mentioned endocardiac functional murmurs that are systolic and diastolic. Here we have Flynn, Graham Steele, and Coombs. So functional murmurs are all the noises that occur in the heart when the valve apparatus is not effective. The main causes of functional murmurs are significant acceleration of blood flow due to nervous excitation, fever, or Graves' disease, reduction of blood viscosity in anemia, relative insufficiency of valve due to expansion of one of ventricles, and reduction of tone of papillary muscle. The following properties of functional murmur help differentiate them from organic murmurs. In most cases of functional murmurs are systolic. Functional murmurs are not permanent and may arise and disappear when the person changes his posture after exercise and during various respiratory phases. They are mostly heard over the pulmonary trunk and less frequently over the heart apex. Functional murmurs are transient and are rarely heard during the entire system. These are soft and blowing sounds. The murmurs are normally heard over a limited area and are not transmitted to long distance from their source. Functional murmurs are not accompanied by other signs of valve affection, such as enlargement of the heart chambers or change in the heart sound. And finally, exocardiac or extracardiac murmurs. They are pericardial murmurs, pleuro-pericardial murmurs, and cardiopulmonary. It should be remembered that murmurs are best heard in certain postures of the patient. Systolic murmurs are increasing in the horizontal position. Diastolic murmurs are better auscultated in a vertical position. Auscultation with raised hands, increased aortic systolic noise during aortic stenosis, aortitis, aortic atherosclerosis. Murmurs associated with damage of mitral valve are better auscultated on the left side. Next are laboratory and instrumental methods of examination. So laboratory tests that are used to detect the heart disease are lipid panel or lipid profile, high sensitivity C-reactive protein, B-type natriuretic peptide, markers of myocardial tissue necrosis such as creatinine kinase B, troponin T and I, myoglobin, LDH, AST, D-dimer, also blood sugar and glucosylated hemoglobin level. So instrumental methods such as ACG. An ACG is a series of waves and deflections recording the heart's electrical activity from a certain view. It is a recording of electric currents generated in the working heart. ACGs are quick, safe, and painless. With this test, doctors are able to check the heart rhythm, see if patients have poor blood flow to the heart muscle, which is called ischemia, diagnose a heart attack, check on things that are abnormal, such as thickened heart muscle, detect if there are significant electrolyte abnormalities, such as high potassium or high or low calcium. Next is echocardiography. A bedside cardiac ultrasound or echocardiogram is a quick point of care ultrasound that allows to visualize and evaluate how the heart is functioning. In addition, bedside echocardiography also allows to evaluate hemodynamic changes and pathological heart disease. This test provides information on the shape, size, workings, valves, and chambers of the heart. Echocardiography may also be combined with Doppler to show the areas of poor blood flow supply to the heart. It shows the areas of the heart muscle that are not contracting normally and previous injury to the heart muscle. Next is Holter monitor. It is a portable ECG that checks the electrical activity of the heart for 1 to 2 days during 24 hours. Doctor may suggest it if he suspects an abnormal heart rhythm in case of palpitations or not enough blood flow to heart muscle. Like the standard ECG, it's painless. The electrodes from the monitor are tapped to the skin. Once they are in place, patient can go home and do all of normal activities except shower. Doctor will ask patient to keep a diary of what he did and any symptoms he noticed. Next is stress testing. For this test, the patient is made to work hard, run on a treadmill, or exercise while the leads of ECG are placed over their body. Those who cannot exercise are given pills to raise their heart rate. The test detects the effect of the exercise on the heart. In patients with atherosclerosis and coronary heart disease, the arteries that are narrowed by plaques cannot supply adequate blood to the heart muscle while it's beating faster. This may lead to shortness of breath and chest pain. The ECG pattern arrhythmia also show a possibility of a coronary artery disease. One more examination is coronary angiography and cardiac catheterization. So this test is invasive test. A dye is injected into the veins to reach the coronary arteries. This is done via coronary catheterization. Thereafter, detailed picture of the blood vessel of the heart are taken using special imaging methods. This is called coronary angiography. So coronary angiography detects blockage in the large coronary arteries. Next part of our lecture is examination of patients with pathology of the digestive system. So the gastrointestinal tract consists of a hollow muscular tube starting from the oral cavity where food enters the mouth, continuing through the pharynx, esophagus, stomach, and intestines to the rectum and anus where food is expelled. There are various accessory organs that assist the tract by secreting enzymes to help break down food into the component nutrients. Thus, the salivary glands, liver, pancreas, and gallbladder have important function in the digestive system. Food is propelled along the length of the gastrointestinal tract by peristaltic movements of the muscular walls. Therefore, in the beginning of our examination of patient is, as always, interviewing. So for the patient with gastrointestinal problems are characteristic next complaints. On the first place, pain in the belly or abdominal pain. Also GAT bleeding. Also regurgitation, constipation, diarrhea, heartburn, nausea and vomiting, dysphagia, also called swallowing problems, bloating, and finally weight gain or loss. So each of the part of gastrointestinal system may be characterized by its own group of symptoms. For example, esophagus disorder are characterized by onset of dysphagia, odynophagia, also called painful swallowing, heartburn, chest pain, hematemesis or melena. Stomach common symptoms are nausea and vomiting, epigastric pain, once again hematemesis or melena, and elicititis. In case of duodenum problems, common symptoms are pain, nausea or vomiting, and hematemesis. Jejunum and ileum common symptoms are pain and diarrhea. Colon common symptoms are diarrhea, pain, and bleeding. Rectum common symptoms are pain urgency, hematohagia, and pruritus or itching. Pancreas common symptoms are pain, weight loss, diarrhea, and steatorrhea. Liver disorders are characterized by such symptoms as jaundice, abdominal pain and swelling in the legs and ankles, itchy skin, dark urine color, pale stool color, or bloody or tear-colored stool, chronic fatigue, nausea or vomiting, loss of appetite, tendency to bruise easily. And gallbladder disease manifests by the appearance of pain in the mid to upper right section of abdomen, nausea or vomiting, fever or chills, chronic diarrhea, jaundice, lighter colored stool, and dark urine. So first mentioned complaint is abdominal pain is important and the leading symptom in diseases of digestive system. So you should ask the patient about location of the pain, namely in which topographic area it is located. According to topographic location, pain in epigastrium region is typical for peptic ulcer, pancreatitis, esophagitis, and gastric cancer. Pain in right hypochondrium is typical for gallstones, hepatitis, cholangitis, cholecystitis, and gastric cancer. Pain in right hypochondrium is typical for gallstones, hepatitis, cholangitis, cholecystitis, and liver abscess. Pain in the left hypochondrium is typical for splenic abscess, splenic rupture, and infarct. Pain in umbilical region may indicate violations such as early appendicitis, mesenteric adenitis, diverticulitis. Location of pain in the right or left lateral flank is typical for renal colic or pyelonephritis. Location of pain in hypogastric area may indicate urinary tract infection, urinary retention, testicular torsion. Finally, location of pain in right iliac area is typical for late appendicitis, Crohn's disease, and ectopic pregnancy, ovarian cyst, and location of pain in left iliac area may indicate such violations as diverticulitis, ulcerative colitis, ectopic pregnancy, and ovarian cysts. Also, we must ask about character of the pain. Is it periodic or paroxysmal, permanent or seasonal, and what intensity of pain is? Next, we must ask about connection of pain with meal. It is fasting pain or after meal. Maybe it is nocturnal or hunger pain, which is associated or which is abated after taking food. One more characteristic sign of pains that we must ask about is radiation of the pain. For example, pain that radiates to the back suggests pancreatitis, cholecystitis. Pain that radiates to the shoulder reflect hepatitis or cholecystitis. And pain that radiates to the groin may indicate nephrolithiasis. And in conclusion, we must ask about factors that ease the pain or relieving factors. They can be vomiting, taking food or soda, spasmolytics, and warmth. Next important complaint is gastrointestinal bleeding, also known as gastrointestinal hemorrhage. Is all forms of bleeding in the gastrointestinal tract from the mouth to the rectum. So bleeding is typically divided into two main types, upper gastrointestinal bleeding and lower gastrointestinal bleeding. Upper gastrointestinal bleeding is from a source between the pharynx to the ligament of Treys, lower from the ligament of Treys to the rectum. An upper source is characterized by hematomesis or vomiting of blood and melena or teristum containing altered blood. Lower gastrointestinal bleeding may be indicated by the passage of fresh red blood rectally, especially in the absence of bloody vomiting. Isolated melena may originate from anywhere between the stomach and the proximal colon. About half of cases of upper gastrointestinal bleeding due to peptic ulcer disease, gastric or duodenal ulcers, esophageal inflammation, and erosive disease are the next most common cause. In those with liver cirrhosis, bleeding is due to esophageal varices. Approximately half of those with peptic ulcer have an Helicobacter pylori infection. Other causes include mallory-based tears, cancer, and angiodysplasia. A number of medications are found to cause upper gastrointestinal bleeding. They are non-steroid anti-inflammatory drugs or COX-2 inhibitors, corticosteroids, and anticoagulants. Lower gastrointestinal bleeding is typically from the colon, rectum, or anus. Common causes include hemorrhoids, cancer, angiodysplasia, ulcerative colitis, Crohn's disease, and autoenteric fistula. Diagnosis of gastrointestinal bleeding typically begins with a medical history and physical examination, along with blood tests. Small amounts of bleeding may be detected by fecal occult blood tests. Endoscopy of the lower and upper gastrointestinal tract may locate the area of bleeding. Medical imaging may be useful in cases that are not clear. Next are regurgitation, constipation, diarrhea. So regurgitation, crutio ructus, that is return of the part of the swallowed food into the mouth due to backward movement of esophagus and stomach with open cardia without contraction of diaphragm and abdominal muscle. Constipation, that is defined as a frequency of defecation of less than 3 times per week. Diarrhea, that is formally defined as an increase in daily stool weight above 200 grams. Typically, the patient also may describe an abnormal increase in stool liquidity and frequency. Diarrhea is considered acute when lasting less than 7 to 14 days and chronic when lasting more than 2 to 3 weeks. Diarrhea with vomiting is almost always associated with gastroenteritis. Diarrhea may occur with pancreatitis, diverticulitis, and occasionally appendicitis. Bloody stool indicates gastrointestinal bleeding. Constipation or difficulty passing stool or gas may be due to an ileus or bowel obstruction. Next is complex of heartburn, dysphagia, nausea, and vomiting. So heartburn, or also called pyrosis, is a specific burning sensation behind the sternum associated with regurgitation or gastric content into the inferior portion of the esophagus. Dysphagia or swallowing problems is defined as a sensation of sticking or obstruction of the passage of food through the mouth, pharynx, or esophagus. Nausea denotes the feeling of an imminent desire to vomit, usually refers to the throat or epigastrium. Nausea often precedes or accompanies vomiting. Vomiting, also called emesis, refers to the forceful oral expulsion of gastric content. Nausea or vomiting generally associated with visceral disorder. Excessive vomiting should raise suspicion of a bowel obstruction or pancreatitis. Lack of vomiting is common in uterine or ovarian disorders. Pain present before vomiting is most likely caused by a disorder that will require surgery. Vomiting that precedes abdominal pain is more likely a gastroenteritis or other non-surgical condition. Next step of patient examination is inspection. So inspection of gastrointestinal system must always begin from oral cavity. Must be done review of lips, teeth, gums, oral mucosa, hard palate, soft palate, and uvula, tongue, and tonsils if present, of course. So lips normally must be symmetrical, pink, smooth, and moist. There should be no growth, lumps, or discolorations of the tissue. Abnormal findings are asymmetrically cyanosis or cherry red or pale color or dryness. Diseases include mucocele, stomatitis, carcinoma, cleft lip, leukoplakia, herpes simplex, etc. Next is tooth condition indicates a person's general health. Teeth should be clean with no decay, white with shiny enamel, and smooth surface and edges. Adults should have a total of 32 teeth. Abnormal findings are missing, loose, and broken teeth. Diseases of the teeth include tooth decay, messed mouth, and Hashimoto's teeth. All sides of the tongue are assessed. The tongue is moved side to side and inspected. It should be pink, moist, smooth, and glistening. Abnormal findings include marked redness, cyanosis, or extreme pallor. Diseases include scrotal or fissure tongue, migratory glossitis or geographic tongue, atrophic glossitis, black hairy tongue, carvial lesions, carcinoma, macroglossia, candidiasis, and leukoplakia. To assess the tonsils, a patient opens their mouth and a tongue blade is used to depress the tongue. A pen light is used to inspect the back of the patient's throat, looking for pink, symmetrical, and normal sized tonsils. Tonsil size is graded as following: 1 plus visible, 2 plus halfway between the tonsillar pillars and the uvula, 3 plus touching the uvula, 4 plus touching each other. Abnormal findings include bright red, enlarged tonsils, or white or yellow tonsillar exudate. Tonsillitis is an inflammation of the tonsils. Now, second step of inspection of gastrointestinal system is inspection of the abdomen. Overview scheme of the abdomen should be as follows. Note the shape, size, symmetry of the abdomen, participation of the anterior abdominal wall in the breathing act, umbilicus position, expression of the subcutaneous veins, and possible presence of scars, eruptions, scratches, visible pulsations, peristalsis, and telangiectasia. In norm, the abdomen is of an oval shape, doesn't enlarge in size, symmetrical, anterior abdominal wall take part in the breathing act, umbilicus is retracted, pronounced venous network, scars, eruptions, telangiectasia, scratches, visible pulsations, and peristalsis are absent. The most common causes of protuberant abdomen are pregnancy, obesity, meteorism, and ascites. Localized bulges in the abdominal wall include ventral hernias, defect in the wall through which tissue protrudes. Next is pronounced venous network on the abdomen, also called caput medusa, is the appearance of distended and engorged superficial epigastric veins, which are seen radiating from the umbilicus across the abdomen. It is also a sign of portal hypertension caused by liver failure. Reason of occurrence of the abdomen scars, eruptions, and scratches are diverse. Physicians should ask the patient about the origin of the symptoms and things they cause and their triggering factors. Next pathological signs that can arise on abdomen are telangiectasias and spider angiomas. So telangiectasias, also known as spider veins, this is small dilated blood vessels that can occur near the surface of the skin or mucous membranes, measuring between 0.5 and 1 millimeter in diameter. Acquired telangiectasias not related to other venous abnormalities, for example, on the face and trunk, can be caused by factors such as Cushing's syndrome, acne rosacea, blepharitis, environmental damage such as that caused by the sun or cold exposure, age, radiation exposure such as that experienced during radiotherapy for the treatment of cancer. Spider angiomas, it is a type of telangiectasias. They are a radial array of tiny arterioles that commonly occur in pregnant women and in patients with hepatic cirrhosis and are associated with pulmonary edema. In men, they are related to high estrogen levels secondary to liver disease or tobacco smoking. Next physical method is palpation of the abdomen. It is the main method of physical examination of the abdominal organs. So here we have superficial, penetrative, and deep sliding systemic palpation of the abdomen. Superficial tentative oriental palpation of the abdomen is helpful in identifying muscular resistance, abdominal tenderness, diastasis recti, and fluctuation symptoms. Normally, in superficial palpation, the abdomen is soft, painless, diastasis recti is absent, fluctuation symptom is negative. Penetrative palpation of the abdomen includes revealing of tenderness points such as gallbladder point, also called Kerr point identification, appendix point, also called Magburn point, duodenum valve projection point, and detection of Schottky-Bloomberg symptom. First one was mentioned Kerr's point. It is projection point of the gallbladder. Places in a point of intersection of the right costal arch with the lateral edge of the right rectus abdominal muscle. Next, Magburni's point in the name given to the point over the right side of the abdomen that is 1/3 of the distance from the anterior superior iliac spine to the umbilicus. This point roughly corresponds to the most common location of the base of the appendix, where it is attached to the cecum. Deep tenderness at Magburni's point known as McBurney's sign, is a sign of acute appendicitis. Next, duodenum bulb projection point places 2 cm from the umbilicus on the bisector of right angle formed by anterior median line and line drawing through the umbilicus. Pain during palpation of this point can occur in case of duodenal ulcers. And next, Schottky-Blumberg sign is a clinical sign that is elicited during physical examination of a patient's abdomen. It refers to point upon removal of pressure rather than application of pressure to the abdomen. Positive Blumberg sign or rebound tenderness is indicative of peritonitis, which can occur in diseases like appendicitis and may occur in ulcerative colitis with rebound tenderness in the right lower quadrant. This method is especially useful in diagnosis appendicitis requiring urgent management. Penetrative palpation of the abdomen also reveals the following symptoms. Murphy's symptom is useful for differentiating pain in the right upper quadrant in gallbladder point. Typically, it is positive in cholecystitis, but negative in choledocholithiasis, pyelonephritis, and ascending cholangitis. Here's symptom, pain on palpation on inspiration at the projection point of the gallbladder. Symptom, Ortner-Greco manifests in disease which are associated with the liver or biliary tract. Most often, it is observed in acute cholecystitis, characterized by a symptom of some soreness on the right side with a slight tapping of the palm to the right on the costal arch. The pain arises from the fact that the doctor produces a slight confusion on the inflamed gallbladder. Under normal condition, patients sometimes cannot feel the pain, feeling only a certain weight on the right side under the ribs. In penetrative palpation, projection points of the gallbladder, duodenal bulb, and appendix are painless. Schottky-Blumberg, Murphy, Kerr's, Ortner-Greco symptom are negative. Next is deep palpation, and it can give us full information about the condition of the abdominal cavity and its organs, as well as their topography. The following sequence is recommended. Sigmoid, thicum with appendix, ascending colon, descending colon, transverse colon, stomach, liver, pancreas, and spleen. In deep palpation, we should assess location, diameter, density, the condition of surface, tenderness, mobility, and presence or absence of rumbling sound of examined organ. We must evaluate condition of each organ under its own characteristics. So, sigmoid colon in normal case is painless with a smooth surface, 1 to 2 centimeters, soft, mobile, grumbling is absent. The cecum in normal case is painless with a smooth surface, 3 and 5 centimeters, rather dense, mobile, grumbling can be heard. The ascending part of the large intestine often is not palpable. Transverse colon in normal case is painless with a smooth surface 2 to 4 centimeters, soft, mobile, crumbling is absent. The descending part of the large intestine often is not palpable. Palpation of the liver, bimanual palpation. In normal case, the inferior margin of the liver is 0.5 centimeters lower than inferior margin of the costal rib. It is painless. The margin is sharpened, soft, and smooth. The pancreas. Because of the deep location of the soft consistency of the gland, palpation of the pancreas is very difficult. The normal pancreas can only be palpated in 4 to 5% of female and 1 to 2% of male with cachexia, relaxed pleurum, and ptosis of internal organs. A normal pancreas is soft, transverse cylinder, 1 and 5 to 3 centimeters in diameter, immobile, and tenderness. Next examination method of the abdomen is percussion. It is useful technique for evaluating the size of the liver and sometimes the spleen. Evaluating gas in the abdomen versus solid or fluid-filled structures. Evaluating for focal areas of the tenderness and peritoneal irritating. Evaluating for the presence of ascites. Because most of the liver is shadowed by the rib cage, assessing its size by palpation is absolutely impossible. Therefore, its percussion must always accompany by palpation of the liver. Percussion of the liver has following potential uses: determination of the liver borders, assessment of its size and configuration. Percussion of the liver, according to Kurlov, is widely used. In order to determine the size of absolute liver dullness, you should identify 5 points by light percussion. Normal liver dimension by Kurlov are by the right midclavicular line 7 centimeters, by the median line 8 centimeters, by the left costal arch 9 centimeters. The liver borders can vary depending on hepatic and extrahepatic changes. Next is percussion of the abdomen. So percuss the 4 quadrants of the abdomen to determine the amount of tympany and dullness. Normally, you should hear tympany because of the air in the underlying structure. Percussion of the liver and spleen produces a dull sound. Dullness may indicate an enlarged uterus, distended urinary bladder, or ascites. Next is percussion pattern for ascites. So one technique for evaluating ascites is assessment of shifting dullness. In the ascitic abdomen, gas-filled bowel loops float to the top while the ascitic fluid falls to the dependent portion of the abdomen. As a result, percussion notes are tympanic over the bowel loops and dull over the surrounding fluid. With the patient lying on his back, map out these areas of dullness and tympany. Then ask the patient to roll on his side and repercuss. The ascites and thus dullness shifts to the side the patient is lying on, while the tympanic areas shift to the top. The next step should be auscultation for the presence and quality of bowel sounds prior to any other forms of manipulations. As these sounds are audible through the abdomen and peristaltic activity is never restricted to one portion of the abdomen, the practice of auscultating in all 4 quadrants provides little useful information. Abdominal sounds are typically generated by peristalsis and blood flow, and sometimes friction roots. Auscultation is performed in 2 or 3 cycles, each time listening for a particular sound rather than trying to listen for all the sounds at the same time. Initially, listen the bowel sounds, then focus on vascular sounds or bruitus. Finally, while rare, check to see if there are any friction roots. Listen for friction roots over the liver and spleen using the bell of the stethoscope. Friction roots is a rare finding that indicates inflammation of the peritoneal surface of the organ from infection, tumor, or infarction. Last in this part is laboratory and instrumental methods of examination or in gastroenterology. So, a complete blood count aids in diagnosis of anemia. It is also detects changes in the blood-formed elements. In adults, GIT bleeding is most common frequent cause of anemia. Can often be detected infection, leukocytosis with a shift of leukocyte formula to the left, eosinophilia, and increase in erythrocyte sedimentation rate indicated the inflammatory process. In blood chemistry include detection of the prothrombin time, serum electrolytes, serum enzyme assay in liver function tests such as aspartate aminotransferase and alanine aminotransferase, blood protein content, iron exchange rates, bilirubin, total serum bilirubin, conjugated bilirubin and unconjugated, and ammonia. Pancreas examination include amylase and lipase, alpha amylase, elastase 1, trypsin, chymotrypsin, elastase, carboxypeptidase, and tumor markers such as CA19-9 and CEA. Next is test for Helicobacter pylori infection. Is recommended if peptic ulcer disease or low-grade gastric malt lymphoma is present. After endoscopic resection of early gastric cancer, first-degree relatives with gastric cancer, and in certain cases of dyspepsia. Several ways of testing exist. Non-invasive test for Helicobacter pylori infection with a blood antibody test, stool antigen test, or with the carbon urea breath test. Also, a urine ELISA test with a 96% sensitivity and 79% specificity is available. None of the test methods is completely fail-safe. Even biopsy is dependent on the location of the biopsy. Blood antibody tests, for example, range from 76 to 48% sensitivity. Some drugs can affect Helicobacter pylori urease activity and give false negative with the urea-based test. The most accurate invasive method for detecting Helicobacter pylori infection is with a histological examination from two sites after endoscopic biopsy, combined with either a rapid urease test or microbial culture. Next is pathology or coprology. It is scientific study and analysis of feces for physiologic and diagnostic purpose. So coprologic analysis includes macroscopic, chemical, microscopic, and bacteriological studies. Next, radiological examination and similar diagnostic procedures are useful in detecting structural and functional disorders of gastrointestinal tract. A plate plain film of the abdomen is generally the first X-ray study that the healthcare providers orders when diagnosing a gastrointestinal problem. This simple film has the ability to reveal abnormalities such as masses, tumors, and strictures, or obstructions to normal movement. Next, a barium enema examination, also known as a lower gastrointestinal series, is a radiographic visualization of the large intestine. This test is usually ordered for a client with a complaint of blood or mucus in the stool or a change in bowel patterns, such as diarrhea or constipation. A barium edema can also detect bowel obstruction for volvulus. This test is usually contraindicated in clients when colon perforation or fistula is suspected. Next is percutaneous transhepatic cholangiography. It is an X-ray study of the biliary duct system. This procedure is usually performed when a client has jaundice or persistent upper abdominal pain even after cholecystectomy. Next, ultrasound. So doctor order an abdominal ultrasound when they are concerned about symptoms such as abdominal pain, repeated vomiting, abnormal liver or kidney function test, or a swollen belly. Abdominal ultrasound test can show the size of the abdominal organs and can help evaluate injuries to or diseases of the abdominal organs. Specific conditions that ultrasound can help diagnose include appendicitis, pyloric stenosis, stones in the kidneys or gallbladder, abdominal masses such as tumors, cysts or abscesses, abnormal fluid in the abdomen. Abdominal ultrasound can be used to guide procedures such as needle biopsies or catheter insertion. Next, endoscopy. So endoscopy is direct visualization of gastrointestinal tract by means of a flexible fibroscopic endoscope. So endoscopy is usually ordered to evaluate bleeding, ulceration, inflammation, masses, tumors, and cancerous lesions. Obtaining specimen for biopsy and cytologic studies, it is also possible through the endoscope. There are several types of endoscopic examination. Esophagogastroduodenoscopy, a visual examination of the esophagus, stomach, and duodenum, and colonoscopy is an endoscopic examination of the entire large bowel. The physician may also obtain tissue biopsy specimen or remove polyps through the endoscope. A colonoscopy is also used to evaluate the cause of chronic diarrhea or locate the source of gastrointestinal bleeding. One more type of endoscopy is capsule endoscopy. It's a procedure that uses a tiny wireless camera to take picture of patient's digestive tract. A capsule endoscopy camera sits inside a vitamin-sized capsule the patient swallows. As the capsule travels through the digestive tract, the camera takes thousands of pictures that are transmitted to a recorder the patient wears on the belt around the waist. Capsule endoscopy helps doctors see inside patient's small intestine, an area that isn't easily reached with more traditional endoscope procedures. Next is endoscopic retrograde cholangiopancreatography. It includes visual and radiographic examination of the liver, gallbladder, and pancreas to identify the cause and location of obstruction. After the cannula is inserted into the main duct, a radiopaque dye is inserted, followed by several X-ray images. The physician may perform a papillotomy or a small incision in the sphincter around the ampulla of Vater to remove gallstones. One more examination is intragastric pH metry, which is widely used method in the evaluating of gastric acidity. But the interpretation of this data is not standardized. Intragastric pH metry is a process of an electrometric measurement of acidity directly in the gastrointestinal tract by a pH catheter and the recorder. Intragastric pH metry include acidity measurement and of esophagus, stomach, and duodenum. Well, students, this is the end of my lecture. Thank you for your attention. If someone has questions, you may stay. All other students, I want to wish you to have a nice weekend. And of course, some of you will meet in class. Now, goodbye, students. Bye-bye, bye-bye, bye-bye.
Thank you, ma'am. Bye, ma'am.
Thank you. Goodbye. Take care.
Bye. Thank you, you too.
Have a nice weekend, ma'am.
Thank you, you too.
Yep. Hello.
Yes, please.
Yep. Where can we get this presentation, like on your mail, or it's not there on the MISA actually?
Of course, it is not on the MISA. Only invitation link we are placing on MISA for you to have opportunity to listen the whole lecture.
Okay.
But as your group mates are not attending Zoom meetings to listen to the lecture, so we decided not to share PDF of the lecture at all. Only those students who are present on Zoom to listen to the lecture can know the information. Other students will not receive this information.
Okay. Thank you. Bye-bye.
Goodbye.
Thank you, ma'am.
You're welcome. Bye-bye.
Дякую, ma'am.
На здоровье. Okay, students, no more questions?
No, ma'am.
No questions. Okay, once again, have a nice weekend. Bye-bye.
You too.